Hello everyone, I'm Dr. Pooja Amarapurkar and I am going to talk to you about immune checkpoint inhibitor related kidney adverse events. The learning objectives of this talk is to understand how these medications work, how they cause immune related adverse events, and how to manage patients with immune checkpoint inhibitor related AKI. Let's start off with the case. I have a 71-year-old female diagnosed with stage 4 non-small cell lung cancer, status post-wedge resection, 4 cycles of chemotherapy, and now transitioned to pembrolizumab monotherapy for about 10 months. At month 10, the patient presented to the oncologist with symptoms of extreme fatigue, nausea, vomiting, and weight loss. This led to the diagnosis of immune-mediated thyroiditis, causing hypothyroidism requiring initiation of levothyroxine. At the same time, she was found to have a serum creatinine of 2.2, up from her baseline of 1, and a serum potassium level that was low at 2.4. Her WBC count was 6.6, but notably 15.5% eosinophils and elevated absolute eosinophil count. Urine analysis was remarkable for 5 to 10 WBCs per high-power field with no blood or protein. She was referred to nephrology for further management. Immune checkpoint inhibitor-induced acute interstitial nephritis was suspected as the cause of her AKI. The diagnosis was supported by eosinophilia, sterile pyuria, and the recent diagnosis of autoimmune thyroiditis. On further evaluation, the patient endorsed intermittent episodes of hypotension. This raised the suspicion of adrenal insufficiency due to autoimmune endocrinopathies from immune checkpoint inhibitors. Further workup showed an ACTH level of less than 5 and a random cortisol level of 2.1, strongly suggesting a central adrenal insufficiency or hypophysitis. Thus, the patient was diagnosed with immune checkpoint inhibitor-related acute interstitial nephritis, for which pembrolizumab was stopped, and she was started on a steroid taper. Hypokalemia due to immune checkpoint inhibitor-related possible renal tubular damage was also diagnosed. Potassium replacement was initiated. Lastly, hypophysitis causing central adrenal insufficiency and autoimmune thyroiditis causing hypothyroidism was also diagnosed. She was referred to endocrinology, continued levothyroxine, started on steroids for the acute interstitial nephritis, and that helped with central adrenal insufficiency as well. A pituitary MRI was ordered. Luckily, 6 weeks later, the creatinine was back to baseline. Potassium improved on supplements. Systemic symptoms were much improved. She was now on physiologic doses of steroids and levothyroxine. Pembrolizumab was held given the state of remission. This case very beautifully illustrates the immune-related adverse events from the checkpoint inhibitors. Let's understand how this happens and how we can help manage these patients a little more. Starting off with, immune checkpoint inhibitors have truly transformed the landscape of cancer therapy. They are currently the cornerstones of several cancers and even in their advanced stages, like melanoma, lung cancer, urothelial cancer, renal cancer, and so forth. These monoclonal antibodies target certain immune checkpoints, such as the CTLA4 and the PD-1, and lead to T-cell activation and anti-tumor activity. However, with this widespread T-cell activation, it can also lead to autoimmune side effects. Immune-related side effects or autoimmune side effects can affect any organ system, and the severity can range from mild to life-threatening, as you just saw in our patient. So let's understand how these medications work. CTLA4 is a checkpoint or a block of activation of immune system. So it prevents immune system activation. An antibody to this molecule takes away the check and thus activates the immune system. Likewise, we have another molecule which is the PD-1. When attached to its ligand PDL1, deactivates the immune system or causes the tumor to escape the immune system. Now, antibodies to these molecules, either the PD-1 or the PDL1, will take away this check on the immune system and thus activate it with the hope of fighting some cancer cells and activating the immune system. Unfortunately, as a consequence of activation of the immune system, there are some immune-related adverse events associated with these medications. They can affect a variety of organ systems, starting from encephalitis to renal manifestations, hypophysitis, thyroiditis, which are the endocrinopathies, myocarditis, and so forth. In the kidney, there are several immune-related adverse events. Classically, the acute interstitial nephritis is thought to be a common cause of acute kidney injury in these patients. But we now know from case reports and case series that the activation of immune system can lead to TMA, renal vasculitis, post-immune glomerular diseases, some podocytopathies, acute tubular necrosis, and some colleagues have even described a special type 5 RTA. Hypokalemia, hyponatremia are some of the other electrolyte abnormalities that are seen with these medications. Now, one might think, what is the incidence of the acute kidney injury seen in patients who are receiving these medications? So, there are several meta-analyses and reports from case series that have been summarized. And in summary, the risk of AKI is about 2 to 5%. And more so when combination of medications of CTLA4 and PD or PD-L1 antibodies are used as compared to when these medications are used by themselves alone. Now, the mechanism of injury of kidney-related immune toxicities are as follows. Once the infusion of immune checkpoint inhibitor occurs and the activation of immune system occurs, there is some loss of self-tolerance and antigenic overlap with the renal tubular cells. Some medications could act as haptans and trigger the immune response. And just generally, the activation of immune system and release of pro-inflammatory and cytokine release might affect the kidneys. All of this in the background of some derangement of the immune system or genetic factors give rise to immune-mediated kidney injury from these medications. Now, what is the diagnostic criteria? Biopsy may not always be possible in these patients. So, however, the definitive diagnosis of checkpoint inhibitor-related nephritis can be done after a kidney biopsy is performed. But we now know that we can establish possible or probable diagnoses with some clinical features with some confidence. Now, the probable diagnosis of a checkpoint inhibitor-related nephritis or AKI can be done in presence of increased in serum creatinine on at least 2 occasions, or the need for renal replacement therapy after clinical risks are reviewed, and the absence of any alternative pathology. And either a sterile pyuria, just as described in our case, and concomitant or recent extrarenal immune-related effects, and the eosinophilia. Now, if you want to establish a possible cause, in that case, either an increase in serum creatinine or the need for renal replacement therapy in a setting where there is no alternative cause of the kidney injury, in that case, a diagnosis of possible immune-related nephritis or AKI can be made. Now, when does one need to biopsy a patient with immune checkpoint-related kidney injury? When you have an unexplained kidney failure with a positive UA for hematuria or proteinuria or nephrotic syndrome or suspicion for systemic illness other than malignancy like lupus, ANCA-vasculitis, and other forms of vasculitis, or if your suspicion is for a kidney toxicity related to other chemotherapy agents, and thus you would want to know that ahead of time to prevent further usage of such medications. Based on the grade and the severity of AKI, one can manage these patients with steroids, and I'll walk you through some of the guidelines we have currently in place for such situations. In setting of grade 1 AKI, one can possibly temporarily hold the medication and monitor. If the AKI is of grade 2 based on the serum creatinine, one can hold the medication and initiate steroids. If there is no improvement in about a week, the steroid dose can be increased. whereas grade 3 and grade 4 AKI seem a little more severe, and in which case permanently discontinuation of medication is appropriate. And in grade 3 AKI, one can even start steroids at a higher dose of 1 to 2 milligrams per kilogram per day, whereas grade 4 additional immunosuppression is recommended. So in summary, as the immune checkpoint inhibitors are more commonly used, we need to be more aware of how these medications work and how this therapy can affect other organ systems as innocent bystanders. Immune-mediated side effects affect several organs, so if somebody presents to the nephrologist, I think it is important for the nephrologist to have information or the knowledge of potential other side effects to look for. In the kidney, there are several manifestations, not just acute interstitial nephritis, acute tubular injury, RTAs, and glomerular diseases, and electrolyte abnormalities have also been reported. Kidney biopsy may be necessary in specific cases. Steroids can be used for management of immune checkpoint inhibitor related AKI. These medications may have to be held or stopped during adverse event times, and thus a multidisciplinary approach with the oncology team and other specialists are necessary in the decision making of such patients. Thank you so much for your time, and I appreciate your listening into this case report.